Only these the city branches which you mentioned in the message can give the entries or other branches as well for Misa News?
Parna, you are muted.
Oh, yeah, I'm so sorry. So, madam, good evening,
Ma'am,
Lakshmi ma'am.
Good evening, Lakshmi ma'am.
Hi. Welcome, welcome. Yeah, Sujata madam. This time is dedicated only to these branches.
These
So,
branches.
yeah, so that they have to share the article.
Right. Okay.
Lakshmi ma'am, you would like to share the presentation?
Right now? Okay.
Yeah. You can share it before we start.
Yeah.
Hi, Rajesh.
Hello, good evening, ma'am.
Good evening, Rajesh sir.
Good evening.
We will start in 2-3 minutes.
Yes.
Yes,
गुड
ma'am.
इव्हनिंग गुड इव्हनिंग एव्हरीबडी. महाशिवरात्रीच्या सगळ्यांना शुभेच्छा.
Good evening.
Good evening, sir.
Oh, नक्की.
Parna, you can see the slides?
Yes, ma'am. Yes, ma'am.
Okay.
Yes, scroll.
अविनाश सर ऑनलाईन काय प्रसाद वगैरे देताय का
लक्ष्मी.
पाठवून?
पाठवू शकतो ऑनलाईन सुद्धा. मग तो काय ऑनलाईनच असेल, चित्र नसतं.
Yes, ma'am.
Lakshmi ma'am, please stop sharing. So,
Yeah.
Yeah.
I have to see how to stop share. Once again.
Ma'am, on top there'll be a
Stop share.
button. Stop sharing.
Wait. I can see share. Stop share to.
no, she has stopped. The sharing has stopped, ma'am.
Okay.
Yes. We see gallery view means sharing. Ganesh, please, the chairpersons and speakers, you make them co-host. Ganesh?
Yes, madam, yes.
Yeah. So, Rajesh, shall we start? It is 6:33.
Yes,
2
ma'am.
minutes.
Good evening, all. Respected President Sam, Dr. Anita Niti ma'am, President-elect Dr. Avinash Gupte sir, Vice President Dr. Saurabh Brade sir, and our news Sam's News editor Dr. Parna Thakur ma'am. Today's speaker Dr. Amla Kudalkar madam. She will be talking on perioperative blood transfusion and strategies in trauma, and Dr. Lakshmi Kumar ma'am, she will be talking on massive blood transfusion and the protocol. The today's chairperson, I would like to welcome Dr. Anil Parak sir and Dr. Surekha Shinde sir and all the audience. We'll continue our SAM symposium on safe anesthesia and saves life. I would like to request Dr. Anita Niti ma'am to brief about the webinar.
Yes, thank you, Rajesh. So, dear friends, I welcome you all for this webinar, and the theme of SAM Symposium webinar is, as you know, safe anesthesia saves lives. So, on this theme, we are taking the topics which are like common to everybody's interest, and today's topic is blood transfusion. So, when we have a patient and who is bleeding, and we are not actually sure whether how to replace, how to know whether to give PCV or to add FFP or platelets or further, other blood components, which investigations to do. So sometimes it's a mixed picture. We are not sure whether the patient is going into DIC, not. And so we have two very good experienced speakers today. So without wasting much time, let us start. And I request I request Dr. Saurabh to introduce Dr. Parak.
Good evening, all. Dr. Anil Parak, sir.
He is a consultant neuroanaesthetist and head Department of Anesthesia, Gleneagles Hospital, Mumbai. He is past president of Indian Society of Neuroanesthesia and Critical Care. He has received many awards, and few of them are Distinguished Professional Service Award in 2022 by ISA NACC. He has also received Literary Excellent Award in 2017 for contribution in the field of medicine. Obviously, he is a famous person and doctor of Mumbai, as he has featured 5 times in the list of top doctors of Mumbai by Times of India and Outlook Magazine Group. Welcome, Dr. Anil Parak, sir.
Thank you.
Avinash, please introduce Dr. Surekha.
Hello, good evening, everybody. It's my pleasure to introduce today's chairperson, Dr. Surekha Shinde, madam. You all of you know her very well. She is a professor of anesthesia at BGMC and Sassoon Hospital, Pune. There, has done fellowship in, I think, academic college of emergency experts in emergency medicine. Then so many fellowship in medical education technology, diploma in medical legal system, certificate course in palliative care. She had 20 publication in index state, national and international journals. She received Cope's Award for Best Paper in Neuroanesthesia and National Award for Poster Presentation. She delivered presentation in various state and national conferences. It's more than 30. She is faculty in MET, Emergency Medicine, and examiner for MD, DNB. And she had extensive contribution to the COVID-19 curtailment effort as an ICU in charge and nodal officer for oxygen supply. She authored of a chapter on COVID management. She awarded President Appreciation Award as a member of National COVID-19 Task Force. She also awarded the late MG Shahade Memorial Award from IMA Pune for contribution to the academia and research. I welcome Dr. Surekha, madam.
Thank you. Thank you so much.
Dr. Parna, ma'am.
Yes. Good evening, all. It's my great pleasure to invite a renowned senior anesthesiologist, Dr. Amla Kodalkar, madam, to this SAMS webinar today. Madam is a professor and head of Department of Anesthesia at State GS Medical College, KM Hospital, Mumbai. She's the immediate past president of ISA Mumbai Metro branch, and she was instrumental in establishing Pain OT, 14-bedded AICU, and Skill Lab in KM Hospital. She's the co-editor of the book Anesthesia for Emergency Surgical Procedure, and she's written several chapters in anesthesia and trauma books. Welcome to you, ma'am.
Yes, it's my
So-
pleasure.
Dr.
I
Dr. Anita, ma'am.
welcome both the speakers, and Dr. Parna has already introduced Dr. Amla, madam. So,
Sir, we'll finish with introduction of Dr. Lakshmi also.
okay.
And yes, Ganesh, please share Lakshmi ma'am's CV. Yes. So it's my pleasure and proud privilege to introduce Dr. Lakshmi Kumar, madam. She is the professor and head of the Department of Anesthesiology and Critical Care at the Amrita Institute of Medical Sciences, Kochi. And she has been conferred multiple fellowships, fellowship in pediatric anesthesia, fellowship in onco anesthesia, and she has done fellowship in critical care also. But she is the leading lady of liver transplant in India, and she has a whooping 1400 liver transplants she has conducted. She has been part of the team. Liver transplants, renal transplants, and also the other pancreatic and bowel transplants. So she's a transplant woman, dear friends. And she has received many awards in her career, and she is a very good orator, and we are very eager to listen to you, ma'am. I welcome Dr. Lakshmi Kumar, ma'am. So now we will start with, I welcome Dr. Amla Kudalkar, madam. Madam, please, you start your lecture. Please start sharing, ma'am. Parak sir, after the first, yes, ma'am.
We can't hear any problem
call
in
madam. I'll call madam.
Yes.
Yeah. So thank you, Dr.
Yes.
Anita and Dr. Rajesh for calling me for this and sharing this important session, because every anesthesiologist in a lifetime come with these situations quite often, sometime in a trauma patient, sometime in a routine normal patients when they are doing a routine surgery. And both the speakers has the vast experience, and I had a pleasure of working with Dr.
Hello,
Lakshmi, so I know her
are
very
you able to hear me
Yes, ma'am. Amla,
Yeah.
ma'am,
on Zoom?
please
Yes,
share
madam.
your screen.
So please share your screen, ma'am.
Can you recess?
We
Start
can
sharing
hear
your.
you, ma'am. We can hear
Madam,
you.
unmute. Madam, unmute
No, but
yourself.
I was already sharing the screen. I think someone will have to stop sharing, then only again because initially when we
Please
checked, I was
reshare.
sharing, no?
Madam,
Amma
please
said Lakshmi
reshare.
ma'am shared her screen.
Yeah, yeah.
So now,
So,
ma'am, you will have to share it again.
yeah.
खालती ते ग्रीन बटन असतील ना मॅम.
Madam, below the screen, in the,
Are you able to see now?
no, ma'am.
No,
No.
ma'am. Not yet, ma'am.
Yes, we can
Yes.
see now.
Yes, yes. Yes,
Yes,
ma'am.
yeah.
It
Please
started.
do full screen, ma'am. Yes.
Yeah.
And slideshow.
Yes.
Yeah, yes. Now it's perfect, ma'am.
Yes, ma'am.
Thank you.
Okay, thank you. Good evening, everyone. And thank you, SAM's office bearers, for inviting me for this webinar. And I will be speaking on perioperative blood transfusion therapy in trauma. This is the institute where I belong to. And rather than, how to give blood and all, I will be discussing the patient blood management. And what is patient blood management is the timely application of evidence-based medical and surgical concepts designed to maintain hemoglobin concentration, optimize hemostasis, that is prevent and aggressively treat coagulopathy and minimize the blood loss, how to use blood judiciously, which also involves retrieval of autologous blood if possible and retransfusion, so as to minimize the allogenic transfusion in an effort to improve patient outcome. This is the definition of patient blood management. Let's see how we use it for today's topic. Let me consider the first patient, which is 32-year-old male patient, a biker, victim of vehicular accident. He was brought to emergency room. Now in E ward, emergency ward, a quick preliminary examination showed that he was conscious, though in pain, and he complained of constant thirst. His pulse was 115 per minute, BP was 90/60. Pulse was rapid and steady. He was pale. The breath sounds were bilaterally equal and audible. Patient seemed to have fracture of the lower limb, fracture of femur. Now, how do we manage? What do ATLS guidelines say? It goes as assess the patient's condition accurately and rapidly. Time really matters here. A detailed history is not essential for evaluation of the patient with acute injuries. Lack of definitive diagnosis should not impede the application of indicated treatment. One can go for triage. that is sorting of patients based on resources required for treatment and resources available at disposal. If required, prepare for transfer and resuscitate and stabilize patients according to priority. So treat the greatest threat to the life first. Severely injured but salvageable patients can be prioritized. So it would go as primary survey, which is ABCDE, followed by secondary survey, which will involve history and head to toe examination, along with adjunct at every survey, and then continue to monitor in the post-resuscitative phase and definitive care. So primary survey would indicate ABCD, that is airway, breathing, circulation, disability and exposure. I will just run through it. Having done the airway maintenance and taking care of breathing and ventilation, now we concentrate on circulation with control of hemorrhage, which is our topic for today. So it's very important to identify and quickly control the hemorrhage. And how it is done? By rapid and accurate assessment of hemodynamic status. Usually these patients who come to ER will be hypotensive. They are obtunded. First, rule out tension pneumothorax, because that can cause this type of picture. Once that is ruled out, and if the hypotension or shock persists, it is almost always due to hemorrhage. So initiate resuscitation. The recognition of shock is the first step in the management of shock. So you have to know that the patient is in shock. And how do we know that the patient is in shock? We have heard this many times, 1 on the floor and 4 more. So floor, look for external bleeding. Now, you are in the ER, you are in charge of emergency ward and the patient has come to you. So your blood management starts from this level. So look for whether there is any external bleeding, whether there is any bleeding in the chest, abdomen, pelvis or retroperitoneum and long bones. So all these potential sites must be scanned quickly. Nowadays, you must have heard POCUS, point of care ultrasound, which is usually a part of all emergency wards. And whenever such patient comes to you, you must do e-fast of these patients. Now, how you will know that the patient is having hemorrhagic shock? Of course, we have seen in the previous slide that there will be evidence of blood loss. The pulse will be rapid, steady, progressive hypotension. The pulse pressure would be narrow, less than 25 millimeters of mercury. So the difference between the systolic and the diastolic pressure. The shock index will be 0.8 to 1. So if it is that, then that means the patient is in shock. The usual value will be 0.5 to 0.7. It is the heart rate divided by blood pressure. And then prolonged capillary filling more than 2 seconds. Another very important point that you should not miss is altered mentation. These will have anxious look. They will be in severe ischemia and hypoxia, they will be rowdy, but otherwise they will be anxious and incoherent. Cold, clammy extremities, pallor, sweating, and decreased urine output. So these are the features which will give you an idea that the patient is in hemorrhagic shock. And then once you know, you will have to find out what level or degree of shock it is. And this all of us know from our residence days that if you, that the commonly what we measure is heart rate, BP, pulse pressure, respiratory rate. So you see according to this table where your patient fits into. Most of the patients were in this category. If you see if it is fracture femur, you can assume that there is always a blood loss of 1.5 liters or more. If it is fracture pelvis, it will be more than 2 liters or so. If it is fracture tibia, it is 500 to 750 ml. So depending upon which fracture the patient has sustained, you can assume that there is already this much blood loss has occurred. So see, according to the parameters and according to the patient's ABG values, which category the patient fits into. And then you will have to vigorously treat these patients as per the gradation. The most important step in this is controlling the hemorrhage. Now, how do we do this? Application of direct pressure using gauze pieces or sponges. Use of topical hemostatic agents like fibrin, sealants, oxidized cellulose, or thrombin-based products, etc. Applying clip to the bleeding vessels or putting ligatures. Now, mind you, in E ward, both surgeons, orthopedic surgeons, and anesthesiologists will be there. So each one carries out his or her own part. Using cautery, bone wax for bleeding from cancellous bones, application of tourniquet, application of external fixators, all this can be done by the team. Now, if there is, this is in case of there is external bleeding, which can be seen and stopped by manual pressure. But if there is internal bleeding, as in body cavities like thorax, abdomen, pelvis, and long bones, it is to be suspected in blunt trauma. Diagnosis is possible with clinical examination with E-FAST, X-ray chest, pelvis, and diagnostic peritoneal lavage. After establishing the source of hemorrhage, second is establishment of venous access. Don't go in for central venous catheterization as it takes long time, it requires expertise, and it may require different positions to be given for the cannulation. Stick to two large bore 16 gauge peripheral venous catheters inserted into a reasonably big veins. Now it's very important that we choose veins early, because once the patient collapses, it is difficult to get good veins. As soon as you take, catheter the veins, initially blood samples are obtained. They are sent for blood grouping, cross-matching, hematocrit, and coagulation profile. Also, you can send this for lactate or bicarb levels. When peripheral lines cannot be accessed, central venous access or intraosseous access in case of children can be secured. Mind you, with the presence of ultrasound, taking lines has become little easier. Venous cut down can be made as a last resort. And the investigations, these are the investigations which I mentioned, like complete blood count. What we are interested mainly in hemoglobin and platelets. Initial hemoglobin, to know the initial hemoglobin is extremely important. Then grouping cross-matching, coagulation studies, and blood gases and lactates. In our institute, in addition, the entire biochemical panel is sent for investigation. So including RFT, LFT, whenever the report comes. And then surgical intervention should be carried out. Now there are multiple teams which are available in ER. So each one will work as per their expertise. So chest decompression, if there is bleeding inside the thorax, application of pelvic stabilizing device, extremity splints by orthopedic surgeons. Then interventional radiological management. If you feel that the patient is bleeding a lot and you cannot control the bleeding by external pressure, it is better to take this patient in the radiological suite and do vessel embolization and then damage control surgery. Now, this is a new term that you may have heard. Next thing is done is replacement of the intravascular volume. So first thing is controlling the bleeding. Second is intravascular volume replacement. Aggressive fluid resuscitation to restore circulating volume and organ perfusion. All fluids should be warm by storing in warm ambience or using a fluid warmer, which is more practical solution. A bolus of 1 liter of crystalloids, isotonic solutions are to be used. Now here, the ringer lactate is preferred over normal saline. Absolute volume of fluid should be based on response to fluid. Aggressive fluid therapy before bleeding control is avoided. Now we are coming to it shortly. Now why I said that ringer lactate is preferred? Because even normal saline is isotonic. But here, with intact liver function, lactate gets converted to bicarbonate and hence does not produce acidosis. Normal saline is avoided as it causes hyperchloremic non-ionic gap acidosis. Use of hypertonic saline has been suggested as it considerably reduces the volume of infusion, but this is mainly preserved for field situation since it is a hyperosmolar solution and used mainly in traumatic brain injury. Though I said that you should give 1 liter of fluid, it should not be at one go. From time to time, after 20 or 250 ml or 500 ml, see how the patient is going to respond. So, if the patients can be rapid responders, if the estimated blood loss to start with is less than 15%, or they can be transient responders, like whenever you are pushing the fluid, the BP comes up. Only when you stop doing that, the BP goes down again. And then minimally responsive or non-responders. Whenever there is already more than 40% of blood loss which has occurred and it is still ongoing, however fluid you are pushing, it is not going to have any effect. In that case, you better concentrate on controlling the hemorrhage rather than pushing pushing the fluids. So depending on how they respond, you can see the patient who are transiently responding or minimally responding, they should definitely undergo surgical intervention first, rather than resuscitation. And in them, you may require to give emergency, that is O negative blood or O positive blood. O negative blood is reserved for females who are belong to childbearing age group. So once you give this fluid, heart rate should come down, blood pressure should come up, urine output should be more than 0.5 ml per kg per hour, and there should be any improvement in bicarbs and lactates. That much response you should get if you are doing fine. It is usually the people keep on pushing fluid till blood is available. Grouping cross matching will take some time, and you see hypotensive patient in front of you, and you just keep pushing whatever fluid that you lay your hands on. But it can do more harm than any good because it causes dilutional coagulopathy. It dilutes the coagulation factors. It disrupts the soft clot that has formed. It causes, fluid logging of all the tissues, mainly the gastrointestinal and cardiac complications. There can be extremity and abdominal compartment syndromes. Hypothermia and electrolyte disturbances also can be result of aggressive volume therapy. So go slow. So what strategies now we should do? How we should give fluid and blood to these patients? One can go for delayed resuscitation. Fluids are given after the bleeding is controlled. So the first thing that you should do is identify the bleeder and try and control it. And it depends on patient's transport time to the definitive trauma care. It is always better to reach the center than to, try out different things in the periphery. And then permissive hypotension, which is achieved by goal-directed resuscitation, that you resuscitate to a systolic BP of less than normal. So if you are taking the normal blood pressure as 90-100 millimeters of mercury, you aim to reach a systolic blood pressure of around 70 to 80 millimeters of mercury, not higher than that. Even mean arterial pressure can be just 50. Fluids are given to reach a level of systolic blood pressure just below the normal tension so that radial pulse is palpable. So this is called as restrictive volume resuscitation or allow permissive hypotension. Any role of colloids? Colloids remain in the vascular compartment for a longer time. They expand the blood volume. They are responsible for maintaining the colloid osmotic pressure. A relatively smaller volume is required. However, they are costly, they have allergic potential, and they affect the cross-matching. They tend to leak out from the capillaries during shock. So the SAFE study said that there is no particular advantage of colloids over crystalloids. The colloids however, whenever you give, colloid to crystalloid ratio should be 1:1.4, not 1:3 as we initially used to believe. So this is controlled resuscitation or permissive hypotension, where you try to strike a balance between maintenance of organ perfusion and tissue oxygenation and avoidance of rebleeding. So if the clot gets popped, the bleeding begins, So unless the bleeder is controlled, you should not raise the blood pressure by overzealous fluid administration. So accept lower than normal blood pressure. Now, what about blood and blood products in trauma? You know that during any trauma, there is tissue injury and there is vascular injury. So there is loss of blood. What we see externally is loss of blood, but mind you, in trauma, there is loss of interstitial fluid as well, because there is tissue destruction. So there is loss of interstitial fluid. Not only that, the interstitial fluid gets shifted. There is a shift of fluid into the intravascular compartment in order to keep the central compartment going, and that also can cause loss of fluid from the interstitium. Now, if you see this familiar equation where the oxygen content of the arterial blood, the major component of oxygen carrying capacity is because of the hemoglobin. So all trauma patients, they have loss of RBCs, hence hemoglobin is reduced, and therefore there is severe decrease in the oxygen carrying capacity. Still, I would say that not all trauma patients need blood. It is only the class 3 and class 4 who would definitely need blood. 1 and 2 can compensate. Why? Because anemia is better tolerated than hypoperfusion. So if you don't have blood in grade 1 and grade 2 shock, you can continue to maintain tissue oxygenation as it is flow dependent rather than hematocrit dependent. So maintain good perfusion, maintain good blood volume. So better to infuse crystalloid till blood is available and achieve normovolemia. Now let's come back to our patient. How was he managed? So in ER, we examined him. Then he had sustained fracture shaft femur, which was open. 2 wide bore IV lines were inserted into peripheral veins as soon as he came, and the blood sample was sent for grouping cross matching. CBC and other biochemical panel, which is the institute protocol, PT-INR, VBG and lactates. 1 liter of Ringer's lactate was started in both the IV lines, so 500 in each. Indwelling urinary catheter was inserted, and a quick e-fast was done to rule out any intraperitoneal collection. It was negative. X-ray pelvis and lower limbs were revealed, displaced fracture shaft femur. By the time all this was done, the reports we received, hemoglobin was 7.8 gram percent. So you have to always remember the initial hematocrit or hemoglobin, because that will give you an idea about the. Now this was before IV fluids were started. So this is what the patient came with. So this will give you an idea about how much blood the patient has lost. So it revealed hemoglobin of 7.8 gram percent. Platelet count was normal, which was expected to be. PT-INR also was normal. Lactates 3.4, so there was some problem with perfusion. And bicarbs were 18 milliequivalent per liter. Application, now orthopedic surgeons applied the temporary femoral traction splint was done to reduce the movement and the bleeding. Injection tranexamic acid was administered, 500 milligram bolus, and 500 was put in pint to reduce the bleeding. 1 unit of blood was summoned and started. Now there was no hurry to operate on this patient, because we took more time in stabilizing the patient. The patient was optimized over 8 hours and was taken up for intramedullary nailing of femur and was done successfully under regional anesthesia, because by that time all the investigations were repeated prior to taking up the patient, because patient received blood, though we did not give plasma as PT-INR was normal, and patient tolerated the procedure well. Intraoperatively, the patient received 1 more unit of blood. Now there is another case. He's a 52-year-old patient, again a case of RTA with high impact motor vehicle collision. He was brought to casualty in a very obtuse state. Pulse was 138 per minute, blood pressure was 80/50, cold clammy skin, altered mental state, E-fast revealed free fluid in the abdomen, and X-ray showed complex pelvic fracture. So now this is a little more complicated case than the previous one. The estimated blood loss was approximately more than 2000 ml. So this is as per that table around grade 4 shock. Even considering his investigations. Now his initial BP was 5.8 gram per cent. Platelet count was 1.25 lakhs per kg. Rarely you will find platelet count to be abnormal. INR was just borderline 1.48, lactates 11.2. So patient had perfusion problem and bicarbs were 14 milliequivalent per liter. So this patient was more severe or has a graver condition than our first patient. So what interventions can be carried out in this patient? Now there is another term, damage control surgery. It provides rapid abbreviated interventions to control life-threatening bleeding and prevent peritoneal contamination. So do just bare minimum to sustain the patient. Then this is do not aim for anatomical repair. So stage 1 would be immediate exploratory laparotomy, control of bleeding, abandonment of definitive surgery, decontamination if it's possible, because many times pelvic fractures would also cause trauma to the bowel, etc. So decontaminate, packing and closure. So just go in, do minimum possible and come out. Stage 2 would be transferring this patient to ICU and take care of their physiology now. So rewarming, correction of acidosis, coagulopathy, electrolyte disturbances, and inotropic support. And then after the patient is stabilized, then planned reoperation for definitive repair whenever the physiology is improved. Now in this case, surgeons wanted to take this patient for external fixator of the pelvis. However, the patient was so bad to start with, even they sort of relented and they applied the pelvic binders, till such time that we were resuscitating these patients. So similar to damage control surgery, there is damage control resuscitation. Now this is rapid hemorrhage control through early administration of blood products in a balanced ratio of 1:1:1. Prevention and immediate correction of coagulopathy. So work proactively and minimization of crystalloid fluids. Permissible hypotension to systolic blood pressure of 70 to 80 millimeters of mercury and till you get radial pulse. Use of blood and blood components, that is hemostatic resuscitation. It aims to achieve correction of intravascular volume deficit, prevents dilution and coagulopathy, treatment of acute coagulopathy, preserve the oxygen carrying capacity, and repair the endothelium. So this is what constitutes the damage control resuscitation. So both damage control surgery and damage control resuscitation go hand in hand. If you know, lethal triad of trauma is very common. Coagulopathy, usually all these trauma patients, they are associated with coagulopathy, hypothermia and acidosis. Once this triad sets in, it is very difficult to recover the patient. And now it is considered as diamond of death. In addition to these three factors, even hypocalcemia is added to it. And unless corrected in time, the patient invariably becomes moribund. Coagulopathy of trauma is a known entity. 1 in 4 patients with major trauma will have acute coagulopathy and it increases the mortality of these patients 4 times. Uncontrolled bleeding is responsible for over 50% of all trauma-related deaths associated with intracranial hemorrhage, and it may lead to SIRS even if the patient survives the original episode. The patient may go in SIRS, sepsis, multi-organ failure, and problems of massive blood transfusion. So why coagulopathy is common in trauma? Exposure of tissues and endothelium. Because trauma, there is widespread tissue injury. Not only tissue, but also the vessels are bare open, and endothelium, injury to endothelium, and there is exposure to coagulation cascade. The liver blood flow is reduced, and there is decreased levels of coagulation factors. Hypothermia leading to reduced platelet adhesion and aggregation. There is crystalloid resuscitation and dilutional coagulopathy. This is because whatever fluid that you have pushed so far till the blood and blood products were available, and also fluid shift from the cells and interstitium into the vascular compartment. Certain colloids which are used for resuscitation, like hydroxyethyl starch, can interfere with clot formation. And then there is transfusion of large quantities of bank blood, which is deficient in 2,3-DPG, platelets, clotting factors, calcium, etc. So whenever you give blood, always make sure that you check the blood date on which the blood was collected. If it is very old blood, then you can return the blood to the bank and ask for fresh blood, because this blood is going to cause more harm than doing any good. Another factor which is detrimental is hypothermia. That is because of the environmental exposure, reduced heat production by under perfused muscles. There is increased heat loss from exposed body cavities, cold intravenous fluids, altered thermoregulation, and because general anesthesia. So hypothermia affects the coagulation badly. It affects the platelet function, adhesion, aggregation. The enzymatic reactions of the coagulation cascade are temperature dependent, which inhibit the coagulation protease activity and thrombin generation. Also, the activity of factor 7A is linearly reduced with temperature, and there is increased fibrinolysis. All these factors perpetuate the coagulopathy. And of course, acidosis, which is so common in severe trauma because of hypovolemia and hypotension. Remember, our patient had bicarb of 14 and lactates of 11 point something. So hypovolemia, hypotension, inadequate tissue perfusion, all these lead to metabolic acidosis. Along with that, there is volume resuscitation by normal saline, which causes hyperchloremic acidosis, and citrate, which is present in the old blood, bank blood. So all these factors will reduce the activity of the coagulation factors. So as a part of patient blood management in trauma, we have to stop the activation of this little triangle. And how do we do that? Prevention is always better than cure. So one thing is always control the hemorrhage at the earliest. Take measures to prevent acidosis, maintain perfusion by increasing cardiac output, closely monitor the patient parameters and coagulation monitors. So the monitoring has to be frequent because it is a very dynamic situation. Whatever a PT, INR or other parameters that were there 2 hours back are not going to be same throughout the surgery. So it is a very dynamic situation. What is the role of HB and HCT? It is use of HB and HCT to quantify the blood loss is debatable. But initial hematocrit or HB closely decides the need for transfusion. Our one patient had HB of 7.8, whereas the second patient had 5.8. Serial measurements will have more sensitivity. So go on doing serially. See how the blood, your therapy or the blood that you are going to give is that you are giving has any effect on the HB or HCT. Hemoglobin of less than 8 gram in a patient of pelvic trauma has close correlation with non-survival. So I don't know how our patient is going to behave. So which blood parameters should be monitored? Now, platelet count may be normal. Even our patient's platelet count was normal, but it is the platelet function that may be abnormal. Now, why that is so? Because at hypothermia, both the platelet adhesion and aggregation suffers. And for that, to know the platelet function, you would require platelet function analyzers, which are available. But they are not available in most of our hospitals. Bedside BT and CT can also be done, but it would depend so much on the endpoint that individual person takes. PTIN are commonly done, but it takes 45 to 60 minutes for the report to come. And by the time the report comes, the patient has deteriorated further. So it really doesn't make sense that you can keep. Nevertheless, in your facility, if there are no other better tests available, you have to keep doing these tests. But not every 4 hourly, every 1 hourly you can do, so that you come to know whether whatever treatment you are doing is doing any good to the patient or no. They do not assess PTI and INR. They do not assess the clot quantity or strength or fibrinolytic activity. In fact, it has been found that APTT is more specific for bad outcomes with higher odds ratio than PT. So if APTT has odds ratio of 4.6, so if APTT is abnormal, more likely that the patient will have bad outcome. Then one can go for fibrinogen. I mean, this is what we have been doing. Fibrinogen degradation product, D-dimers. These are the surrogate markers of consumption of clotting factors. So it is not possible to take decision based on these test results in acute settings. In these patients, what helps is point of care monitoring. So it is the point of care assessment of viscoelastic properties of clot formation. Commonly used ones are TG, TEC, like thromboelastography, or ROTEM, rotational or thromboelectrometry. So, because they will give you an idea about clot initiation, clot strength, and fibrinolysis. So, the results of this will be equivalent to what results you get from PTT, fibrinogen level, platelet count, and clot lysis. So, all in one, you will get the idea about the patient's thromboelastogram, that is coagulation. This is how you will get the result. And if you go, I mean, you can refer to the books also. The interpretation will be given. And if you check, for example, this is the R value. This is when the clot begins. So this is clotting time. This is time till initiation of fibrin clot formation. Normally, it should be 5 to 10 minutes. Now, whenever it is increased, that is, whenever there is clotting time is increased, you will find R to be high, and then what you should give? FFP and protamine. So this is what you should give. For example, say alpha angle. Alpha angle is rate at which the fibrin cross-linking occurs. So it is normally is 45 to 75. If it is decreased, that means there is reduced fibrinogen. So what you should give in these settings? Cryoprecipitate or direct fibrinogen product that you can give. So the single reading can give you an idea about which factor of coagulation is affected and what treatment you must give to the patient. So, and it is point of care. The entire thing takes around 5 to 10 minutes for initiation, and fibrinolysis will take almost 40 minutes. So within that, you come to know, and this can happen at the bedside. So you don't have to run to the blood bank or the pathology lab. So you can take decisions depending on this. So this is same TG interpretation. Now, mind you, I mean, most of the private nursing homes may not have this facility, but it is always in our hospital. Let me tell you, our hospital has only two places where this is available. One is in liver transplant unit. So whenever such patients come to us, even obstetric hemorrhage patient come to us, we just tell the liver transplant, we request them that you can do you can run the test on our patient so that we can do. So these are the TEG guided transfusion practices.
Okay.
Then plasma. This is universal thought plasma of AB blood group should be immediately available. Usually most of the blood groups, blood banks will have it. AB blood is rare and is present in just 4% donors. So AB plasma may not be there. Hence, group A plasma with low titers of anti-B is used. The titer needs to be determined at the time of donation. So in emergency, even untested group A plasma is acceptable. And once patient available, then patient should be switched to group specific plasma as soon as the group is determined. Then use of cryoprecipitated and fibrinogen concentrate. So it contains 200 to 250 milligrams of fibrinogen per unit. However, it takes time to thaw and the expiry time is just 6 hours after thawing. I think most of the these products, I'm sure Dr. Lakshmi will be discussing, and let me just run through them. So whenever your thromboelastogram tells you that there is problem with clot formation, you can go for a cryoprecipitate or fibrinogen concentrate. And other hemostatic factors like recombinant activated factor 7 or prothrombin complex concentrate, which rapidly makes vitamin K dependent clotting factors available. So this also one can use in case of severe hemorrhage. Tranexamic acid, again, it is recommended for in trauma patients. It is an antifibrinolytic agent that inhibits the formation of plasmin and responsible for clot breakdown. So it improves the duration and firmness of clot to enhance the hemostasis. So administration of tranexamic acid within 3 hours of injury, it results in modest but significant reduction in overall and bleeding related mortality. POC, that is point of carrying whole blood PT or INR. Now this is also possible. You don't have to send the sample to the lab. It happens at the bedside, but you should again have that facility of this. So we still don't have it and we have not used it. So I won't be able to tell you much, but there is a significant decrease in the turnover time, TAT, and laboratory costs if you have this bedside equipment available. Now about the patient was taken up for external fixator pelvis after trying to, stabilize him in the E ward. Initially, pelvic binder was given. Then we tried to correct the coagulopathy. The surgeons insisted on taking him for external fixator pelvis. Throughout the surgery, VP continued to remain on lower side even after administration of 5 units of PRBC or similar units of plasma and 6 RDPs. INR was from 1.4, it went to 1.9. Then shifted to trauma ICU, correction of physiology was attempted. Now this patient came as quite late. He was not as well preserved as the first patient. Had a stormy course of 1 week, but somehow he survived the ordeal. So just to summarize, patient blood management in trauma, you should go for quick primary and secondary survey, assessment of loss of blood volume and degree of shock, sending blood for grouping and cross-matching, treating hypothermia, acidosis and coagulopathy proactively, PRBCs, FFPs and platelets in proportion. Usually it is 1:1:1, but individual blood can have its own MTP, massive blood transfusion protocol, and it could be two PRBCs and 1 FFP and 1 platelet. You have to decide at the beginning. Consider adjuvants if needed, and monitor coagulation profile, preferably point of care, bedside, and HB and HCT frequently, and intervene immediately if there is any problem at any level. Thank you all of you for patient listening. Thank you.
Thank you, Dr. Amla, for the nice and very compact and covering every aspect of the trauma patients, how we go about the blood transfusion. I think we'll take the questions after the second lecture.
Yes,
Uh,
sir.
Yes,
Yes,
sir,
yes.
we can do that. Do you want to comment on anything about this or?
Dr. Amla, thank you so much for taking us through to the two cases. It's a case-based kind of scenario, and you very well were adherent to the trauma trauma protocol, trauma resuscitation protocol. And I think since the advent of focus and other adjuvants and e-fast, trauma resuscitation has gone a long way in saving the lives. I think thanks to you for making it very simple and very lucid also in a very short span of time. Thank you so much.
Thank you, madam.
Yeah.
So now I'll request Dr. Lakshmi to start to share her screen, please.
Amla ma'am, please stop sharing.
Just hold on. Huh? Yeah. Yeah.
Can you see my slides and am I audible?
Yes, ma'am.
Yes.
Okay. So,
Yes, ma'am. Yes.
yeah, good evening to all. And thank you, Anita, for inviting me. And when she called, I really could not say no. I haven't put the kind of effort which my previous speaker has put. She has done a beautiful representation of the topic. And a few things that I might go to say may seem like an overlap. But I want you to pay some attention because I think there is a different aspect in a massive blood transfusion than what we have been trained to do. To me, when the patient comes with a massive blood transfusion, sorry, here I have to. The instinct is your brain stops working and your hand starts working, right? So you have somebody pushing the blood, somebody pushing plasma, somebody running for albumin, somebody running fluids. There is no accountability and we just do a mad rush. While this may be necessary for an initial management, I believe as we are advancing, we need to have a better understanding, sometimes because the excessive use of products may lead to complications. So let me just go on, and the time is 7:27. So my model for discussion is what really is massive blood transfusion, briefly on the lethal triad, the current concepts of the coagulopathy in the setting of massive bleeding, point of care testing, do we really need it? What are current practices in India across the world, complications of transfusion, and then I will have to finish by involving AI in massive blood transfusion, artificial intelligence. So when I ask myself, what is the definition of massive blood transfusion? Or when I ask my students, nobody comes up with a straightforward answer. I thought they didn't know, but then I realized it's because nobody really has a clear answer of what massive blood transfusion is. I might say it is 10 units over 24 hours. Somebody says so many ml per minute. So there is actually a systematic review which looks at massive transfusion. And the reason why it is difficult is because you're looking at different types of patients. Some coming with trauma, some coming with orthopedics, some coming with obstetrics. So there are about 8,500 references from about 30 studies and 15 different definitions of massive blood transfusion. What seems to be most acceptable to us today is a transfusion of more than 10 units of packed cells in 24 hours. It can also mean a transfusion of 3 to 5 units of red blood cells in 1 to 6 hours. I'll tell you where there is a heterogeneity. When we talk of MBT, everybody only mentions about the packed cells. Nobody talks about platelets, nobody talks about plasma, right? So this particular research topic has said we really need to have a better consensus on what massive transfusion means. But I don't think the solutions are that simple because they're extremely variable and dynamic from patient to patient. So why do we need to have a lecture on massive blood transfusion? So, surgery has advanced. A tumor that is encasing the IVC or is enclosing into the superior mesenteric artery was considered inoperable about 10 years ago, but the surgeons don't do that anymore. Today we operate and, whenever there is vascular involvement, there is a chance for sudden hypotension. Then, of course, as my previous speaker Dr. Amala has alluded, trauma is increasing. Everybody has a motorbike and the Swiggy and Zomato, they drive so recklessly that my heart is in my mouth when I watch them on the driving on the road. So when you have faster vehicles, more motorbikers, younger, reckless drivers, you're bound to have motor vehicle accidents. But I will not be talking on those kind of massive blood transfusion. I know this is a repeat, but some of you may need to know what really, when I am giving a bottle of blood to a patient, what am I actually expecting can happen? Any patient, when you give a blood, can have a hemolytic transfusion reaction. They can have shivering, febrile transfusion, TRALI, which is transfusion-associated lung injury, TACO, transfusion-associated cardiac overload, bacterial sepsis that can occur, and then, of course, the lethal triad components, hypocalcemia, acidosis, coagulopathy, and hypo or hyperkalemia. Long term, there are problems we need to remember. The immune modulation, the microchimerism, which I am told can actually lead to the manifestation of some lymphatic malignancies, graft versus host, and transfusion transmitted diseases. Right? I think my previous speaker has spoken about the lethal triad and also about the diamond, which involves the hypocalcemia. Now, when we are talking about what is massive blood transfusion and its management, we all agree on three things. You need to definitely control the hemorrhage. You need to have improved blood resuscitation and an aggressive treatment of coagulopathy and hemostatic effects. But that's really the point at which all of us will agree. There are huge differences in understanding beliefs and management across the country. Right. Now, what is the impact of hypothermia and why does it occur? You see a patient who's coming, or just see a patient who's had a massive liver injury or a splenic injuries wheeled from the OR. The surgeon is also reckless. They don't use their warm mops. They don't cover the bowel when they are operating. And you are also, oh, hurry, get the next blood, get the next blood. And then your inline warmers may not be working or you're running some other product. So you run a cold bottle of blood because you have to match the volume losses. So when you have all these, one patient under anesthesia losing his mechanisms for regulation of blood temperature, the excessive bowel and body surface area being exposed, you transfusing cold products, and of course, the body's autoregulatory mechanisms failing, you can have hypothermia. And the hypothermia affects the metabolism of citrate, which is added as an anticoagulant in all the units of blood. And what does citrate cause? It is an anticoagulant, and it also causes a metabolic alkalosis. The hepatic clearance of these citrate gets affected. There are the presence of acute phase reactants. Drug clearance is slowed down, and the clotting factors are less in a hypothermic environment. Now, it is stated that there is a 10% decrease in coagulation factor activity for every degree fall in temperature, and overall coagulation is impaired below 33 degrees. Now, the question I want you to think about is, most of the time when you're having a massive blood loss, even if your patient is being warmed and you've had a sudden loss and you're trying to warm the patient, temperatures are anywhere between 33 to 34. Does each patient manifest the same predicted loss in coagulation factor activity, or is it variable? Now, when you send a lab test, say you're sending the CBC to look for platelets, the PT-INR and the APTT, these tests will only measure the blood coagulation at a presumed temperature of 37 degrees. It is not actually corrected to 33 or 34. What about the coagulopathy? Now, Dr. Amala was talking about the extreme coagulopathy in the INR that is present. Now, are all the INRs of 1.9 and 2, are they as coagulopathic as you would believe? Now, I will just bring to your attention, I know it is not in the context of massive transfusion. Let us take the case of a simple liver donor, a young, healthy 35-year-old man who is willing to donate 70% of the liver for his loved one, be it his spouse or father or mother or whoever. Now, if I don't know how many do hepatic surgeries, but if one does a INR at the end of the surgery, 6 hours later or 12 hours later, you will find an INR of 1.9 or 2.5. Does this mean that this patient is going to bleed from the cut surface of the liver? No. Now, if you do a point of care testing on this gentleman, you will find that the TEG which Dr. Amala was talking about is not showing a long R. It in fact shows a normal R and a nearly higher maximum amplitude. So why does this happen? Is that INR of 1.9 wrong? Is the lab misreading it? No, the lab is correctly reading it. But unfortunately, the lab only looks at one particular aspect of coagulation and does not look at the naturally occurring anticoagulants, protein C and protein S, right? So you are only seeing an undercoagulation because of the INR. And if you were to look at the coagulation factors in the presence of the naturally occurring anticoagulants and the presence of acute phase reactants, anybody, all of us, if we have to undergo a surgery and post-op fibrinogen is going to be increased. And the maximum amplitude of the TEG is contributed 50% by fibrinogen. So I'm not mixing an elective donor with a massive blood transfusion, but I'm just trying to highlight that an INR of 1.5 or 2 need not be corrected. If you want me to put this into better perspective, there have been donors, not in our country, outside, who have actually received plasma for the correction of this so-called coagulopathy and developed pulmonary embolism. So when you're treating numbers, you need to ask yourself if you're doing good or if you're doing bad. And this is a question I want all of us to ponder about at the end of this conversation. I'm not refuting what has been told. It is a brilliant presentation, but we need to also look at a component that we haven't understood well. Right now, it is believed that 25 to 30% of patients who present to the emergency room are coagulopathic. Now, let me ask this question. If a patient who is 7 months or 8 months pregnant has some other accident and comes to the emergency ward, is her fibrinogen going to be low or high? I thought pregnancy was associated with hyperfibrinogenemia. So why should we think that she's coagulopathic and needs all of this because the alpha angle is not the alpha angle? You think that she would need 1:1:1. Is the liver surgery. Now, liver recipient, patients with liver disease will have a platelet count of 60,000 and INR maybe 1.6. And what do they have in their portal veins? A portal vein thrombosis. Now, why would a clot form in a person with this? So that is the rebalanced state of coagulation in a liver patient. Now, I know I'm dealing more with livers and hence that analogy, but I just want you to understand that patients who may have massive blood transfusion actually have a different spectrum, and we need to look at each of them differently. So now, if I give, supposing I am doing a Whipple surgery and the surgeon actually loses about 800 ml suddenly while he is approaching the superior mesenteric vein, and I transfuse about 3 to 4 units of packed cells, am I making this patient coagulopathic? Right? So do I need to transfuse plasma and do I need to transfuse platelets? That's a question which we need to think about and not really look at lab values, but go beyond into point of care testing, right? So it said 75% of patients who received more than 20 units of red blood cell products had a platelet count of 50,000 at presentation. But does it mean that you have to transfuse platelets to them? Right? And 100% of the patients who received more than 12 units of products had a prolonged INR. So were they all coagulopathic? Now, this is again a question we need to dwell upon. Right. So what we believed 10 years ago is that we need to target a hematocrit of about 30%, the mean platelet count of about 85, and you need to get the mean coagulation factor activity to about 62% of normal. So this was what was begun in Iraq, where you need to give 1 red blood cell, 1 plasma, and 1 platelets. But let me then ask you, the fibrin binding and the stability of the clot is done by fibrinogen. So why was not cryoprecipitate included in this? Should we not be transfusing cryoprecipitate as well? Well, we believed, and I still think it is okay if a patient comes in shock, as Madam explained her second patient presenting at, it is absolutely reasonable to do a 2:1:1. Maybe you would want to add fibrinogen so as to ensure clotting. But beyond that is when I believe there is a scope for point of care testing guided transfusion. So what about the acidosis and why does it occur? Well, the patient may have hypotension. In hypotension, he cannot perfuse his organs. When the end organs are not perfused, he gets acidotic. If you transfuse blood, and as Madam had said, the duration of the blood, the storage of the blood is more than 10 days, you could have a further deterioration. Now, it is true that citrate, if it is metabolized, may actually contribute to alkalosis. And if you get a patient with acidosis after you believe you've done the initial resuscitation and control the bleeding, you should look for other causes and manage. Right? So when the pH decreases from, all of us know that we look at ABGs in trauma or hemorrhages where we see a pH of 7.4, 7.0. So what happens to the clotting factors? Factor 7A activity decreases by 90%. And there was a time when activated factor 7 was used as a treatment for uncontrollable hemorrhage. Today, the role of activated factor 7 is negligible. Very, very limited circumstances when you would want to use them. Similarly, other coagulation factors are decreased, and there is also an inhibition of thrombin. The electrolyte abnormalities you need to remember: if you transfuse blood too rapidly, too fast, under high pressures, or old blood, you're going to have hyperkalemia. And this occurs because this red blood cell membrane associated in sodium potassium ATPase pump is inactivated. Now, when you irradiate red blood cells, you can increase the potassium, but this potassium can be reduced by washing. They say hyperkalemia occurs more in children than in adults. And we all know that when you have crush injury or trauma, because of the muscle released hyperkalemia, you can have high increases in potassium. But when the bleeding is settled and there's a restoration of the membrane ATPase, you can have a hypokalemia as well. Again, if you're giving normal saline, I think in traumatic brain injury or some neurological conditions, when you're just giving normal saline, which does not contain electrolytes, you may compound a hypokalemia. Now, citrate, we have mentioned, when you use large volumes of red blood cells containing citrate, you may have a citrate toxicity. And this will manifest as a prolonged QT interval, hypotension with lowered pulse pressures. You may have a decreased myocardial contractility, elevated CVP, and left ventricular end diastolic pressure. So they may overlap with signs and symptoms of hypocalcemia, and you may end with, and the patient may get a ventricular fibrillation or a pulsus electrical activity as a form of arrest. Now, a prolonged QT could also be a differential diagnosis of hypomagnesemia, and magnesium ions bind to citrate that is present in the blood. So these are things you need to keep in mind while resuscitating the patient. And for this, the lab test may help you in appropriate correction.
Good.
Now, what is different now? Right now, this is I think this protocol is something that was published in 2020 or 2021. And this is a massive transfusion protocol for trauma, right? They mentioned that if the systolic blood pressure is less than 70, or it is between 70 to 90 with tachycardia, and there is a torso or pelvic fracture, with an abdominal ultrasound showing one body region to be involved, they say this is when they activate their massive transfusion protocol. But then look at the next box, right? So they have said use a thromboelastogram and also check the activated clotting time. Right now, we all know that if you, those who are familiar with the tech, I know the activated clotting time, many of you doing cardiac surgery would be using, right? And those who are familiar with the tech will know what you need to do. If the angle, the alpha angle is low, it is a manifestation of fibrinogen deficiency, and a cryoprecipitate is what is commonly available in India. I think the fibrinogen concentrate is also available. Not too many people are as happy as they are with prothrombin complex concentrates, right? And here they have added platelets, although the angle would more specifically represent the cryoprecipitate, right? And then they say look for lysis. Of course, tranexamate is indicated in 3 conditions today: in spine surgeries, in trauma, as well as in obstetrics. So a massive transfusion protocol, I know I'm linking this to trauma, does involve the use of a point of care testing. Now, let me come to the area of the field of work that I work the most in. So before, when we were doing donors, this is a hepatic liver donor, right? It used to be open surgery. So if there was a tear in the IVC, all the surgeon needed to do was to put a clamp until they took their sutures and released. But what happens when they become very sophisticated and want to use high technology? This is a robotic. Now, this is a picture published by my friend, and I borrowed it from his journal. This is very clear, and this is not what it usually looks. So what you're going to see here is, besides looking at the screen, you will have two surgeons who are near the arms and the main surgeon sitting at the console. So what is going to happen if he accidentally nicks the IVC here? How is he going to reach the patient? Now, this, I think, is a situation when you could have a massive transfusion. But the problem here is it's going to take 5 minutes to undock the robotic arms at a cost of I don't know how many crores. This machine is really valuable. They have to save the arms. And then by the time the surgeon is able to make an incision to look at the IVC, guaranteed 4 to 5 minutes will definitely elapse. And what happens if the patient is bleeding at the rate of 500 ml per minute? Not 500 ml, it would be more like a liter per minute for 3 to 4 minutes. The rest is your imagination. And this is not that it doesn't happen. In a learning center, it will happen. So you're left to contend with a 30-degree systolic, and you don't know whether to push adrenaline to volume, and it's hell. Right? So these are situations that do occur, and you need to know that this massive transfusion can occur under most unexpected circumstances. So this is a journal which is published in 2024. And this has actually come from Klaus Godlinger, who himself has been associated with the ROTEM. It is true that a little bit of the protocols here are biased towards the use of the ROTEM over the thromboelastogram. But this is what he says. Have transfusion protocols, has science gone eerie when you're looking at the goal-directed bleeding management? Has a massive blood transfusion gone a change with the way things go about? Now, I know Madam has spoken about this, but briefly about point of care testing, right? So thromboelastogram, this was the oldest version that came about 20 years ago. Here, there is a pin and then there is a cup. And the cup moves through an arc of the circle around a fixed pin. And as the blood thickens, right, as the cup rotates, the curve is produced, and you see that little curve above. That is what is produced on a computer screen, right? Like Madam said, there are various parameters. Now, as she correctly said, if this is prolonged, you give clotting factors. It is also possible it is due to excessive heparin. So if you neutralize, this is a kaolin tank. If you add heparinase, you will correctly know if it is due to heparin or coagulation factor deficiency. Right? The alpha angle reflects the fibrinogen, and so also the clotting constant called K, while this, the way the stomach of the curve is a combination of platelets as well as fibrinogen, and this represents lysis. Right. Now, the thromboelastogram initially started with just the kaolin tank, which is what you saw earlier in this picture. And when there were so many parallels saying that the ROTEM was having different reagents, they came up with something called a functional level of fibrinogen, right? So this is a patient who has a liver disease. And what would you expect the levels of fibrinogen to be? I would expect it to be below 100 or at least below 150. But the levels that you see here are larger. And the reason for this is that this particular reagent, although it looks at the fibrinogen, does not look at the impact of fibrin stabilizing factor, factor 13. Okay, so there are some shortcomings in the technology, and we need to understand when we use which test and why. So the second, the so-called superior alternative to a thromboelastogram is a rotational thromboelastometry. While the main problem with a thromboelastogram is that the pin is fixed and the cup rotates, making it extremely vulnerable to movement, external movement. If it's kept in a room and somebody opens the door forcefully, the peg would go haywire and you'll have to start again. So the ROTEM came as a more robust thing where the cup was actually fixed and you have a central pin or a piston which has an optical mirror. Like the other, a measured sample of blood with a proper reagent is added to initiate the coagulation. And as the fibrin builds up and the clot thickens, the movement of the piston is reflected by the mirror onto a source, and this will give you the curve or the trace that is specific for the ROTEM. Right. Now, this is very, very, very similar to the thromboelastogram with one difference. It has 4 primarily 4 different reagents that can be used to assess. If I were to do a liver case, I would just use 2 reagents, the XTEM, which essentially reflects the extrinsic clotting pathway, and the FIPTEM, which will tell me about fibrinogen. Right? There are other reagents, but again, you must understand that each test comes with a cost. And when you're working, you need to justify the cost that you use for the performance of the test. And therefore, in most of the cases in perioperative condition, the XTEM and FIPTEM are commonly used. In cardiac, you might use the APTEM, which involves the involvement of aprotinin. Right? So they have said that this particular article has said that when a patient comes to you with massive bleeding and you need to do a massive blood transfusion, you definitely need to do the initial resuscitation. And then you need to, within the say 15 or 20 minutes, you need to get a point of care testing. So when now in the ROTEM, I'm just going back. So there is something called A5, which is the amplitude at 5 minutes. So the USP of ROTEM over TEG was 1, it is more robust. 2, it has got very specific reagents. 3, it is done by a pipette and you don't have to manually do it. 4, the speed of giving its results, right? In 5 minutes, it said that it could give you the strength of the clot that is being formed, right? So when this A5 in the XTEM, which looks as the extrinsic pathway, was less than 35 millimeters, and the FIPTEM A5 was less than 12, it said that these patients have an intrinsic coagulopathy and you need to correct multiple products, right? So instead of believing that nearly 75% of the patients who are presenting with massive hemorrhage are coagulopathic, this author, again, he's somebody who's done loads and loads and loads of work on coagulation and probably understands it better than any of us. Only 25 patients with massive hemorrhage are actually coagulopathic. And by overcorrecting, you have the potential to cause some harm besides doing good. Right? Now, in the same article, they have said there are 3 trends in practices across the world. I love the Goldilocks. So there are 3 things. One, what is practiced in US is giving the blood and products in a predefined fixed ratio so as to get control of hemorrhage and of hemodynamics. The other is a European concept where they say you do the initial, you treat and control the cause of hemorrhage, and you do what is called massive transfusion prevention strategy. You address the bleeding so that the bleeding stops and you don't have to give more components. And in Scandinavia, they have what is called as a hybrid technology. They use the initial shock pack treatment and then go by goal-directed guidelines for the control of bleeding. So again, this is a repeat. US transfusion of blood and blood products in a predefined ratio to control bleeding and hemodynamics. Europe, the protocol is called massive transfusion avoiding protocols. Like if you thought that it was a crush injury or it was, so again, I'm diverting. It is into, I leave trauma and talk about a surgical bleed. You have an aneurysm that has ruptured. So you know that putting a clip above the aneurysm is going to, so the protocols would actually move towards making the patient get into the theater for the control of bleeding first. And the whole aim is to avoid massive transfusion. And I said, as in Scandinavia, they start with a shock pack and then move on to goal-directed blood management. Now, why are we so worried about the blood? Why not give more and accept it? It's okay. We just use a little money and a little bit of resources. Now, I think all of you will know that large volumes of transfusion ends up as an independent risk factor for the development of multiple organ dysfunction. And this is in the setting of trauma patient. It is also there in the setting of liver transplant. Now, systemic inflammatory response is known to occur with, now, although I've written trauma, these are replicable for any major surgery, including liver or vascular and obstetrics, right? And more transfusions in the first 24 hours of presentation would mean that there's a higher incidence of mortality. Now, blood transfusion, there is an immunosuppression consequent to transfusion. there are mechanisms of immunomodulation that are modified or altered by this transfusion. There is an implication for cancer recurrence. And then I told about the microchimerism, something I don't understand too well, but the allogenic donor leukocytes actually engraft in the recipient and may lead to the formation of abnormal stem cell lines in the future. And you also have engraftment to the donor hematopoietic cell. So transfusion is not without its problems. TRALI, or the transfusion-associated lung injury, is a lung injury, or by your lung ratios, PaO2, FiO2 ratios, that occurs within 6 hours of transfusion. And it is not clearly associated with risk factors for ALI or ARDS. Delayed TRALI is also known to occur with sepsis, burns, or injury. Right. Now, what causes TRALI? Is it the packed cells? Is it the plasma, or is it platelets? Right. So it says that it's 1 in 5,000 for packed cells, 1 in 2,000 for FFP, and 1 in 400 for platelets. Therefore, platelets becomes the most proclaimed risk factor. But these authors also say that the transfusion-associated lung injury is significantly but not solely associated in the presence of leukocyte and alloantibodies in donor plasma. And they say that women after pregnancy are known to manifest such antibodies, and suggest that restricting the source of plasma for FFP production to men seems likely to reduce the incidence of TRALI. I don't know, in a country where getting donors is an issue, I'm not sure if we will be able to entirely do this. Right. So this leaves us again in a confused state. If I were just to give only packed cells and not plasma, I'm going to cause dilutional coagulopathy. If I allow the patient to bleed, he's going to have a consumptive coagulopathy. If I give too much, I cause immunogenic reactions, and then there is TRALI and graft versus host. So what am I supposed to do? Now, is this proper? Right? This was a study that was published in JAMA in the year 2015, right, by Holcomb and his associates. And they actually looked at 2 strategies of transfusion in patients who presented with severe trauma. This was called the PROPER trial. The red blood cells, plasma platelets and red blood cells were either 1:1:1 or a 1:1:2, like Dr. Amla mentioned, that you can give 2 blood cells and 1 FFP and 1 platelets, or you can give 1:1:1. So what were we all saying? That if you give too much, you're going to have problems. And then again, if you give too many products, you're going to have increased incidence of lung injury, sepsis, kidney injury, etc., etc. But let's see what this study said. Now, they said, irrespective of 1:1:1 or 1:1:2, there was no difference in mortality at 24 hours. Although it appears to be slightly higher in the 1:1:2 group, 12.7 versus 17. And even at 30 days, when it was 22 versus 26, about 680 patients were included in the study. They said that exsanguination, which was a predominant cause of death in first 24 hours, was, however, decreased in the 1:1:1 group versus the 1:1:2. Then achieving hemostasis was better in the 1:1:1 in 86% versus 78%. FFP was higher, right? 7 units in the 1:1 versus 5 units in the 1:1:2. And platelets were 12 versus 6. And these were significantly different, right? The blood cells were the same, however, but they said that looking for 23 pre-specified complications, including ARDS, multi-organ failure, venous thromboembolism, sepsis, or transfusion-related complications were not different. So this is a study which is contrary to many of the studies that are published to say that organ dysfunction, sepsis, kidney injury, etc., are higher when you give more of products. Right? This is a study which says excessive plasma in trauma patients was associated with a 12-fold increase in ARDS, new organ injury 6%, and pneumonia 4%. Now, in traumatic brain injury, it is said that the administration of platelets to a person who might have been on antiplatelet therapy causes an increase in mortality. Right? And these authors also say that TACO, circulatory overload, immune modulation, and infectious complications account for more than 60% of the mortality associated with massive blood transfusion. So, what is the meaning of goal-directed massive transfusion strategies? First is, of course, you treat the patient who presents with shock, address the pre-existing conditions that would deter your correction, which is acidosis, hypocalcemia, hypothermia, anemia. Now, in Europe, and this is a European protocol, a tech-based algorithm within the first half an hour, because labs will take at least 45 minutes to 1 hour or even longer, a tech-based algorithm within half an hour can guide you. And it said that this center where they practice it, they use 50-minute time for the correction of coagulopathy in a neurological, in a traumatic brain injury. It's not in every vascular, but in traumatic brain injury, right? So this article again talks about the pillars in management. Again, as I have alluded to earlier, don't treat numbers in the absence of bleeding. If you just find a platelet count of 50,000 and the patient is not bleeding, there is actually no need to correct, right? And as I have said, point of care testing using specified markers such as the ROTEM, XTEM, or the FIBTEM can identify patients who are actually coagulopathic and will need aggressive correction of all the coagulation factors. And this can help to treat patients and prevent the massive blood transfusion. Now, they also say that when you're doing your static tests and point of care testing, if you find a normal point of care testing, it's a huge negative predictive value for the occurrence of massive blood transfusion. This doesn't mean just keep looking at that and don't treat. Treat the cause of the bleeding first. But remember that your goal is to contain the bleeding and avoid an overtransfusion, particularly when it's not indicated. Like I've said, that giving FFP may actually cause a thrombosis or a pulmonary embolism. Right now, I'm just finishing my slides in the next 4-5 slides. And you can see that this slide is made with gamma. Right. And this is my colleague who taught me that slides can be made within a very short time if you haven't prepared using the artificial intelligence, right? Somehow it didn't seem acceptable to me. I felt I had to know what I was speaking about. But this is a very good thing which talks about the massive blood transfusion for trauma score and says it's a new tool designed to predict the need for massive blood transfusion in trauma, particularly in settings with limited pre-hospital resources. And this was conducted at one trauma center in southern Thailand. So it looks at 4 components: age 60 years or older, base excess -10, which means your bicarbonate is going to be 16 or lesser, a lactate which is more than 4, and a heart rate more than 105. So they say that if you have a score more than 4, there's a very high likelihood of needing massive blood transfusion, while less than 4 suggests a lower risk. Now, this is just exclusively put up to show that artificial intelligence can do a lot of things, probably even tell us who's going to bleed. And this is the article that has been published about the validation of a prediction model for massive blood transfusion during surgery using intraoperative hemodynamic monitoring data. So some of you in the audience would be using the Edwards Hemosphere, which is essentially an artificial intelligence developed technology that was based on some 3,500 patients that were looked at, about 146 indices, and developed an AI prediction that would tell when the patient is going to get hypotensive. This is a ditto of that, where they have used intraoperative hemodynamic monitoring data, right? So they looked at nearly 18,000 patients, 17,986. And then among them, 416 patients underwent massive transfusion during the operation. So with this, they developed a prediction model for predicting massive blood transfusion. So they found, using their massive transfusion index, which was more than the 90th percentile, those patients had a 47.5-fold increase in the risk for massive transfusion compared with those who had an index less than the 80th percentile. So as I said, every sphere is having artificial intelligence coming up. And I'm sure this could be something of the future when you actually look at patients and the machine actually tells you he's going to need MBT or not. So this is just for your thought. I will finish my presentation now. I just think I've taken 30-35 minutes. So massive blood transfusion in non-trauma conditions can occur in the setting of liver surgery, obstetrics, and vascular surgery. Remember, while thinking we are doing good to correct the coagulopathy, extremely large volume transfusion definitely carry complications. Over transfusions can also result in complications. The point of care testing can help in identifying the 25% coagulopathic patients who may need product guided management, and artificial intelligence prediction indices may help in preempting perioperative massive bleeding, a thing to think of the future. Thank you. I'm stopping sharing.
Yeah. Thank you, Dr. Lakshmi, for a brilliant talk, and you have covered all the aspects since when we started the clinical practice and what is today, and including the AI, how is going to change our practice. And we have come when there was no blood components available. We used to do whole blood transfusion, and now you are so specific in giving blood components in, and now the blood concentration factors and all. And as you rightly said, until unless you change your practice since the beginning, what you learned, you are going to harm the patients. Yes. And whatever the had come in the past, now slowly, this changing the mindsets and new evidence are showing what we were doing about 20 years back. Still, we were saving some patient. I'm not saying we were killing all the patient, but now how the scenario has changed in last 40 years of the practice, which I have seen. So thank you very much for, and I'm privileged to work with you.
Yes.
And
I think I'm privileged to. It's a pleasure to see you once again. Yeah.
So that's my privilege to working with you for some time, but I learned a lot of things from you, and now the house is open, and there are
Thank you.
certain questions which I think Dr.
May
yeah.
I say something?
Yeah, please.
Thank you, Dr. Lakshmi Kumar. It's a brilliant presentation, I must say. And your experience in liver transplant actually showing in your talk, because every day and night you are dealing with massive blood transfusion and coagulation hassles. And from your talk, I can relate to one thing, that the blanket rule is not to be applied for any case. It has to be case scenario based, kind of tailor-made approach for everything. So giving too less or giving too more, I mean, that's a kind of balancing act, and lot of surrogate markers has to be used, like rotem and everything. And really very touched with your kind of experience and the kind of research you have made into making this presentation. Thank you so much. It's a brilliant talk. Thank you so much. I think the house is open for question and answers. We must be having many.
Yes, so let us take questions. Thank you, Dr. Lakshmi ma'am and Dr. Amla ma'am, for brilliant presentations. And there is a question that what is the status of balanced salt solutions in such situations? I think he means to ask
me?
Balanced salt
or to
solution.
Amla madam?
Yeah, Amla ma'am. Question to Amla ma'am.
Okay.
Yeah. Actually, I have written the answer, but anyway, let me tell again. That balance salt solutions, they are the mainstay, because initially, whenever we see trauma, it is not always the loss of blood, but there is also loss of interstitial fluid, because of the tissue trauma. Some of the fluid goes out, some of the fluid goes into the vascular compartment to compensate for the loss there. So both vascular compartment as well as the interstitial compartment are deficit. So it is always better to start your crystalloid as a resuscitation, and there this is the best, that is balanced salt solution, because it resembles your plasma composition. It is isotonic, almost isotonic, and resembles the plasma composition. Even normal saline is also isotonic, but whenever you need to give very high quantities of normal saline, say 1.5 liters, then you may land up in having hyperchloremic acidosis. So balanced salt solution is always better. So Ringer's lactate or plasma lye would be our choice.
Yes. So actually, I want to know at how many places is the rotum or the tag is available. Um,
Yeah, I think that's a limitation actually. I know when I spoke, it was something that could, spur a controversy. But I think it's also probably our role to make the institution or administration understand the potential role. Because I'm telling you, in liver, like when we, INR 2, and okay, the liver transplant recipient comes, the INR is 5. Platelets are 28,000. And then you do a TEG or a rotum, it is normal. There is so much of a difference, right? We don't transfuse. INR 5, I don't transfuse. And in fact, say if you want, remove the femoral line. So that's how confident we have become, because I've had the privilege to actually compare both and know how different they can be. So having realized that, I think we need to think a little beyond. I know, like, I'm sure Dr. Parak would remember a few times when trauma cases came when we were at Seven Hills. The whole thing was a mad rush. Somebody putting a line, somebody trying to get an arterial, somebody giving, it was all mayhem. Now, while that initial resuscitation is important, I think if today, provided we have the facilities, in 20 minutes, you're able to put a sample for a point of care testing, I think our management could change a bit. And we all know giving less is better for the patient.
Ma'am, one comment or a kind of query I have. When I was going to the literature, yeah, you said about the definitions of massive BT. Like we also being in a medical college, we keep on asking the definition. There are plenty of definitions. So when I was
Correct.
going to the literature, there was one definition I found out, like massive, there is one ultra massive kind of a transfusion protocol where more than 20 units are transfused. So with so much extensive experience of liver transplant, have been any incidences we had to give so much? Is it just a curiosity I'm
Actually,
asking you?
as the surgeons get better,
Yeah.
we hardly bleed, like you probably nowadays, most established centers will give 2 to 3.
So
Right.
I thought
So
of
in the
asking you.
beginning, we had given 40 to 50 and all that. I don't know. I probably didn't know about all this. We did have the rotum and not rotum, sorry, TEG. But yes, we have given, but the surgical team gets better. You don't need to transfuse so much.
Madam, are you using rapid infuser quite commonly in your setup?
We used to have it, but as I said, the surgical team gets better. The need for it is not so much. There is, I think people trained in UK keep asking for it, but for us, having 2 people hold the bag is just good. And putting the pressure bag helps. So we don't use. I don't use it now.
I think we wish that all of us can come to your setup and watch how you do all these cases of liver transplant. Actually.
Yeah, but
It's
that's what
quite
I'm saying.
inspiring.
Now things are very cool. It's actually boring for some time.
Okay.
Yeah.
It's so heartening to know this, that you just end up giving only 2 or 3, because I
Yes.
remember we used to be almost 20 units. I mean, averagely, some time ago for liver transplants.
Yes.
So
Yeah, I think as the center gets experienced, the surgeons definitely get better. When they explant, they do it so well that most centers who've done good volumes will not have that problem.
It's the most dynamic kind of milieu interior when you think about liver transplant, isn't it? All
It's very, there's a lot to learn. And
yes.
in fact, I actually attended a meeting by Claude Gorlinger yesterday. And I just went because there was a commitment and I had to go, but I learned so much. I just understood his understanding was so much, so much. So all of us cannot reach that level. It's too high. But you need to, like he says, no, if there are some patients who are on vitamin K, warfarin, this particular thing will be high, etc., etc. Itna to we don't know, but I think it's enough if we know that a point of care testing can change the way
Yes,
you think
definitely.
about managing
Definitely.
coagulation. And it's probably up to us, because in Europe, it has become a mandate, a level grade 1 and grade 1A level of recommendation. US is a little behind, but I think it's up to us to make our administration understand that they would probably be saving on hospital stay or something if they can invest in this. I mean, this is just a thought. Yeah.
yes, I just want to know, ma'am, if you say that the prothrombin time was very much prolonged and still the tag was normal. So,
Normal.
I mean, why it happens? What Factors
What
are
causes that? Yeah,
yes.
exactly what I'm saying. No, the thromboelastogram is like an in vitro.
Like
It
your own,
simulates
what
what's in the
happens
body.
in your
And in the
body.
body, you have a combination of procoagulant as well as anticoagulant. And when you don't have a liver, even though you don't have as much as clotting factors, the normally occurring anticoagulation, protein C, protein S, fibrinolysis inhibitors, all of them are decreased. So because of that, you get a rebalanced state, and you definitely need to have a point of care testing to understand what the clotting is. If you give too much, then you can have graft problems, like, the graft thrombosis, etc., can occur. So the recommendations are that you give less.
So I like Madam's one sentence that don't treat the numbers, don't treat the prothrombin
Yes,
time, treat the
correct,
patient.
correct.
So one of the comment which I would like to make about Dr. Amla, what she has said about the use of colloids, because
Yes.
now it's a hardly a lot of literature has come about acute renal problems and all. And what they have also recommended is you cannot use more than 30 ml of per kg of body weight. So I just want to ask Dr. Lakshmi, what is your protocol? As such, now they say not more than 30 ml per kg of body weight for initial resuscitations.
You're talking about a patient who presents in shock.
Yeah, colloids. Yes, use
I'm
of
not sure. Colloids, 30 ml for a 50 kg man would be 1.5 liters.
right.
I think for an initial resusc you would give, and if you're not able to control the cause, you're going to probably try your hand with everything. You can't, some of my colleagues like to use albumin, but it's so expensive, and if the patient is actually losing it all out, it's a waste. So you sometimes give, then there are, even though I know gelatins are not accepted by all, we don't regularly use them. But I think it is okay to use it when a patient is massively bleeding until you get the control and then correct it with the correct products. That's something I've seen a few liver centers do. They say anyway that everything is going out, we'll give one gelatin. There is a problem with anaphylaxis, we understand, but that's there with albumin as well. So I wouldn't stick to that rule of 1.5 liters. If I manage to control the cause by that time, that's fine. If I don't and there's ongoing losses, I will put whatever gets in my hand.
Okay. What is your experience about the cell saver? Because when you are talking about the preventive aspects and
Right.
the minimum transfusions.
Yes. So the cell saver was actually introduced, and many people felt that it was a necessity, particularly in liver transplants and major surgeries like aneurysms and some cardiovascular surgery. We used the cell saver, and I think we looked at our data from about 150 patients, and we found that the cost of using the circuit for the cell saver was 10,000 to 12,000 per patient. Now, the cell saver, while it can give you back the red blood cells, cannot give you plasma, platelets, or cryo. So if the patient has a component failure, you have to transfuse those. So in our result, we found that a cell saver saved the transfusion of 2 units of packed cell per patient, but did not reduce the transfusion of other products. So slowly, its use is also getting less and less. For one, our surgeons have got better. And two, there isn't major advantage, except I've even asked for a rare blood group. We did a patient with O negative. I asked, would you like to use? Then they said, madam, we'll tell you. And we didn't use it because the patient got about 2 or 3 units only.
So what is your one tip which I like to give to all to prevent hypothermia? Because the center where you are working, that's a one, or we are working in a corporate hospital where we have like fluid warmers and all. In an emergency where there is nothing. So what is your tip for prevent the hypothermia,
I
right?
think the biggest thing I can say is that the anesthetist is meticulous. A lot of things, it's just paying attention. Is the head covered? Are the legs wrapped up? Or you don't have wet fluids which constantly fall on the patient. And of course, either bear huggers fluid warmers is something that I have. In fact, in liver, they even give me the hemotherm. So I really can't complain. But I think just being meticulous, and if the patient is hypothermic, we do ask the surgeon to put warm fluid and suck it out repeatedly. That can get the temperature up by 1 to 1.5 degrees centigrade. I think it's just being meticulous.
Thank you.
Right.
There is a question.
Just one comment.
Yes,
Sorry.
madam. Yeah, please go ahead.
Yeah. So just one comment about hypothermia. So years back in a private nursing home, I'd done one case where there was obstetric hemorrhage, abruption, and overnight we had about 30 pints in a private setup. That too, blood products and FFP, and there were no warming over there. But that patient came out so well, and we could extubate, in the morning. So I think uh, it depends on the cause of the hemorrhage. Obstetric patients are very young, so I think they can take it also. So it, I think it depends on what is the pathology of the blood loss and the age of the patient. Many variables, but where there were no resources, also we could, save the patient. Thank you.
As Dr. Lakshmi said, it is always better to prevent it. It is extremely difficult to treat a established coagulopathy or hypothermia. It is always better to take those
Yes.
extra steps to prevent all these things.
Yes, absolutely right. And actually, what Madam said about the extrapolation of liver patients to the massive blood transfusion. So at least wherever the facility for TEG and ROTEM is available, there at least if you, along with the ABG, if you do TEG or ROTEM, whatever is available, I think you can definitely avoid more blood transfusion. So thank you for excellent presentations.
Now there is a question: is it recommended to warm the blood?
Mm-hmm. Yes.
No, somebody has put it in the chat.
Yes, ma'am. So, do you want to answer it?
Yeah, I can answer. You definitely need to warm the blood, but it depends upon how you warm it.
Yeah.
Right?
Yeah.
So it actually should be placed in a water bath with a temperature not greater than 38 to 40. Right?
Exactly.
If you go higher, you can cause hemolysis and your patient will get jaundice the next day. I know somebody also inadvertently tried warming the blood in a microwave. This will cause cell lysis. And I mean, we are laughing, but then that person didn't know. So, like if we can warm our cup of tea and coffee, why not blood? So, this will cause the red blood cell to lyse because a microwave heats by heating the liquid inside the cell. So the cell lyses, you get hyperkalemia, you'll get breakdown of hemoglobin, and you're actually causing harm to the patient and can produce acute kidney injury. If you should warm the patient. The ideal way is to have an inline fluid warmer like how I do. If you don't, then you need to make sure you have these igloo water baths at the correct temperature. Make sure it is not too hot because it can damage the red blood cells.
Only then
Somebody tried putting the even ringer lactate crystalloid bottle in the microwave. Even that is not advocated at all, because at temperatures it can release plasticizers. I mean, that also we had seen.
the only thing I can say that you should yourself should check the temperature of the water, as Dr.
Yeah.
Lakshmi said. You should not rely on your ward boys. Just put in the many times what happened that when we're in a hurry, just tell the ward boy or some nurse to put in the water, irrespective of what the temperature is that.
Someone is asking, when there is massive bleeding more than 200 ml, how many units to transfuse and how fast? As advanced testing is
200,
not available.
2000,
It must be
2000.
2000. It must be. Yeah.
Yeah. Should I answer? Madam, Dr. Amla wants to answer? Should I? It's for
Anyone?
me.
Yeah.
Massive blood transfusion. So
It is not that every drop of blood that is lost has to be replaced, you know. Basically, it is very important to maintain the volume more than the the RBC
Hematocrit.
content. So initially, I would give around 2 to 3 bags of PRBC, and then again check, because along with that you are giving FFP as well as platelets or even crystalloids are going on. If the patient is hemodynamically stable, the rest of the blood you can wait for some time. You know, it should not be given at one go. After 12 hours, again you can give 1 or 2 pints. All 2000 need not be going at one go, one after the other.
Right. Yeah, I think Dr. Samir, that's it. Like maybe two units of packed cells, and then you'd probably send your ABG. Look at the way the patient's BP is holding, and then look for ongoing coagulopathy. If the patient is coagulopathic, you will actually see it on the field, right? And then you take a call. A sudden loss of 1.5 doesn't always need FFP, right? We've just seen Whipples, they would lose 800. If it occurs rather suddenly, the odds are high that you would have to give a unit of FFP. I'm not denying that. But you could probably, once the cause of the bleed, if it's a sudden loss due to a clamp slipping or something, it'll come back to normal as soon as, in the same speed with which it occurred. So I think it's instinct, giving 2 units blood, looking at the ABG, hemoglobin, looking at the bleeding, etc., seeing if the bleeding is continuing. And if it's continuing, I would probably give the third blood and definitely add an FFP at that point. Right. And then if I feel it is indicated, I would ask for a TEG. See, even though I work in a center with a TEG, I did a large hepatoblastoma for a 15-year-old who lost about 1.5 liters. I don't need to do a TEG always. Right. I'm comfortable with the way I'm handling. Child lost about 800 to 1 liter. I think we gave 1 unit of blood or 2 units of blood, and that's it, nothing else. The INR post-op was about 2.2. We don't worry. We do put an epidural, and an epidural is safe because of what I said about the intrinsic hyperfibrinogenemia that occurs after surgery.
So in the same way, there is a question with availability of tag or point of care monitoring. Is this possibility of change the guidelines of avoiding the regional anesthesia if INR is more than 1.5? Yes.
Yeah, so there is, yeah, it's a very, very good question. It's a question I asked about 10, 15 years ago. Now, to put that as a guideline, you need to have a randomized trial which compared somebody doing the INR and somebody doing this. So that courage we haven't got because there are guidelines that say you cannot keep an epidural, with an INR of more than 1.5. So because of that, it's difficult to form, but a lot of bleeding coagulation guidelines, European particularly, has started introducing point of care testing, and it's come as level of evidence 1A. So I haven't read all the papers, but I have an impression of them from what I've listened to and heard. But I guess if you're interested, you could read up. It's definitely coming in European literature. It'll be a matter of time before it comes to us. Saying you can put an epidural looking at point of care testing will not be able to come as a guideline for the reason that I've just said.
One question, any thoughts on use of prothrombin concentrate or indication of using prothrombin concentrates?
Absolutely. So that's the new kid on the block, which is probably a good thing. The sad thing that comes is its price. But again, in particularly liver patients, we worry about the portal hypertension, and the portal hypertension increases with more volume. So if I gave 4 units of FFP to control a bleeding, I can actually increase the portal pressures and worsen the bleed. So to avoid that situation, if you had the facility, it is available freely in India. You can use a reconstituted 4-factor prothrombin concentrate. So it has all the right factors to you and can be given in a smaller volume. There's a paper published by Piyush from Fortis, where he says by using that, he had lesser complications and lesser hospital stay.
Is there any increased incidence of thrombosis following PCC?
In this particular paper, he has not mentioned, and I haven't come across studies where they say that there is a prothrombotic thing, but you will have to be careful when you transfuse. It's to avoid 4-FFP transfusion that you would look at PCC. Or when the bleeding is not getting controlled, you have some urgent measures. Factor 7 has gone. We don't use it anymore. But there is a role for PCC.
Or
and
when the products are not available. When the products are not available, that's
either they are not available or you are kind of burning the bridges and not reaching anywhere. Then PCC sometimes helps because it gives those factors in a concentrated dose all over a short time. It helps.
Madam, I had used PCC once. So
Yeah.
patient was in liver failure. and she came with DIC, and she was a pregnant patient, and she was in liver failure and DIC, and because of
She
massive
was
blood
something like a HELP
transfusions,
syndrome. HELP
yes,
syndrome.
HELP syndrome, yes.
Okay.
So she was bleeding from everywhere, and because of rapid transfusion, she went into failure. So we gave
Failure. What
PCC
failure?
and
Rapid
heart
heart
failure.
failure. Cardiac failure.
Heart
Okay.
failure, cardiac failure. So she went into failure, and she also had some, because she was septic and her heart was also affected. So we had used PCC, and then her bleeding stopped. So it was a very good
Works.
experience.
It
Yes,
works. I think
it
the
works
dose is
very
some
well.
12.5 units per kg or something. And again, this
Yeah.
Dr. Claus mentions that although the dose recommended is 25, you don't want to overcorrect. You start with a slightly lower end of the
Lower.
recommended dose and it works.
Yes, yes. So,
But PCC is available everywhere now in smaller district places also. PCC is
Right.
available
It's
because
expensive, isn't it? 50,000, 60,000 for
60,000 or something.
but
But
it,
yeah.
it can be
Mhm.
stored.
But see, mm,
Yeah, that's again they
Good
say, no,
half-life, that is-
in these war, this thing, you don't need to group match,
Yeah.
right? It is just
yes.
instantly available. And I think the shelf life is also pretty good.
Yes.
So there are a lot of advantages, and PCC is gaining as much popularity as a point of care testing. It's definitely come in as the things for massive transfusions.
Yes.
There's a question: is Novo 7 helpful? What is Novo 7?
Is it Zygris that you're talking about, Nova 7, or is it activated factor 7? Nova 7 is activated factor 7. Yeah,
Activated.
perhaps the role of factor 7 is gone or it's going. Before we used to believe that it was the initiator of that tissue factor related coagulation. But somehow today it's nearly not recommended. It has been removed from the transfusion protocols. So no, the answer to factor 7 is no. It's not being recommended. It has actually been removed from one of these guidelines.
Madam, any role on desmopressin, madam? They do mention in MBT actually.
I don't know. I don't know about desmopressin. I think renal related bleeding and coagulopathy, perhaps desmopressin is used. I haven't used it much in my practice.
PCC are also suggested to reverse NOAC. Can PCC reverse NOAC's effect of NOACs?
Oh, can it yes. So the thing is, that's another thing that is being spoken about. When a patient who is on say a valve, prosthetic valve, and on anticoagulation comes, or a patient who's on warfarin comes for surgery, or he's so precarious that you don't want to actually stop and wait for the 2-3 days when you bridge with a low molecular weight heparin. It is okay to continue it as close to surgery and reverse the coagulopathy using PCC. That is again one of the newer recommendations that is discussed.
Okay.
Yes, it can reverse the novel
oral
anticoagulants.
anticoagulants, newer
Yes.
oral anticoagulants.
I think if it is at factor 10, you may have to have the PCC containing the factor 10 because they would be factor 10 inhibitors, right? Many of them. So you probably need to check that factor 10 is there. But yes, it is known to occur, reverse the coagulation if a patient has had trauma or is undergoing a major surgery while on anticoagulation.
There's a question that do we always wait for hemostasis or is it advocated to transfuse blood during active bleeding?
See, you need to save the patient. Going hypotensive is also harmful for the patient and the organ systems. So you can, that initial, the shock pack or the initial resuscitation strategy is fine. But somewhere during that strategy, if you can have the facility and can incorporate a point of care testing, that's another statement which I wish to make. I believe in a surgery like a liver transplant or a major bleed, the value of these lab tests are diminishing. I used to do it 3 times during a transplant, which normally takes 12 hours, but I've reduced it to 2, and I just need to do 1 when I hand over the patient to the ICU team to say, yehi NK values. And the values are what I told you, 38 platelets, INR 5. And no, neither is the ICU team worried, nor am I worried. So the impact of lab testing has come down. So what was I trying to say? I forgot. I forgot what I was trying to say. Something I was trying to say and I forgot.
I think we all have gained a lot of knowledge
Yes,
and
definitely.
with your experience, and we can implement in our day-to-day practice. And it should be, as Dr. Surekha also highlighted, that it should be customized to the individual. We should not be like following all the things what has been narrated. Yes, we have to prevent the
Yes.
damage by lethal triad and all. That has to be in mind. That's all I can say.
Thank you, madam, for such a wonderful presentation and very active discussion, one-to-one. Thank you so much. We wish to hear more from you, ma'am, in future.
Thank you. Thank you, Dr. Parak, Dr. Anita,
Yeah.
and Dr. Amla.
So, it's my
So is it
pleasure
okay
to
Thank
talk
you,
to
madam.
you. Yeah. after
Yeah.
long- yeah.
I should meet you in Bombay sometime
Yes.
soon.
Yes, yes. October 9th to 12th, we are having meetings. So I'll send an invitation. Dr. Amla is organizing our Maharashtra meeting. So keep yourself free from 9 to 12, whatever we are.
I will.
Okay.
I will. Thank you.
Thank you very
And good
much.
night.
Good
Thank
night.
you. Thank you so
Thank you, everyone. Thank you.
Yes,
It was
Dr.
it
Rajesh.
was a excellent, yes, it was a very excellent webinar on blood transfusion. Good evening, everyone. I'm very much pleased to be here on behalf of SAN to convey our gratitude. I would like to extend our heartfelt thanks to our esteemed speaker, Dr. Amla Kudakar ma'am, for sharing her valuable insight on the perioperative blood transfusion strategies in the trauma. And I'm very thankful to Dr. Lakshmi Kumar madam for sharing her wide experience with a deep knowledge on massive blood transfusion protocols. I'm obliged and thankful to today's chairperson, Dr. Anil Parak sir and Dr. Surekha Shinde madam for their expert opinion and valuable experience. I'm also very much thankful to Dr. Anita Nisi ma'am, Dr. Avinash Bhosle sir, Dr. Saurabh Berde sir, and Dr. Parna Thakkar ma'am. A special thanks to all the attendees who took time to join us today. Your active participation makes our webinar worthwhile. Thank you once again, you all, and we look forward to your continued support in the future webinar. Thank you all.
Thank you. Good night.
Thank you. Thank you.
Thank you. Good night. Good night.
Please stop recording, Ganesh.
Anita,
Yes.
छान झाला webinar. Very active. It is for everybody's interest, not this topic actually. And there are lot many confusions and guidelines. So people are
Yes,
very
yes.
confused actually.
And actually, there is a lot to read. A lot of material is there.
Yeah, very much. It's very confusing also. And sometimes such a massive blood transfusion, you don't know whether you are giving 6 or whether you're giving 10. You just in a fit of time, you keep giving and doing more harm than doing some good actually.
Yes.
I remember in Sasun hospital, do you? We just keep one person is just for pushing blood.
Pushing. So I have given 20 units of
Yeah.
physics even at JJ.
I know. I know. Thank you.
Yes, thank
चलो,
you.
you very much.
वंडरफुल आणि सर्वांना आजच्या दिवसाच्या खूप खूप शुभेच्छा.
Yes. महाशिवरात्रीच्या
महाशिवरात्र.
महाशिवरात्रीची शुभेच्छा.
हर हर महादेव.
हर हर महादेव.
चालेल. Thank you. Bye. Taking your leave.
Good night.
Yes. Bye.